Good afternoon, everyone, and welcome to the What's Next edition of our Health Innovation Series. I'm grateful to be a guest here on the traditional, ancestral, and unceded homelands of the Musqueam, the Squamish, and the Tsleil-Waututh peoples. We're grateful for their stewardship of this land, and we are grateful for the privilege of building the new St. Paul's Hospital at the Jim Pattison Medical Center. In the spirit of humility, accountability, and compassion, we pledge to infuse the new St. Paul's with meaningful reconciliation and to engage, serve, and support the Indigenous patients, families, and caregivers. I was advised not to describe today's speakers as mavericks, so I won't do that, but I will say they personify the concept of moonshot thinking. Together with their teams, they're tackling huge community-wide problems: the opioid crisis in urban health, the pandemic, and the need to accelerate the pace of research, and the imperative of improving care for people with heart disease in the wake of our aging population and overburdened healthcare system. I can illustrate this with a quote from Professor Alain Cribier, the renowned French cardiologist often called the father of TAVI. He said, "When you think of something really radical, for the first 10 years, people say you're crazy. It's only in the last 10 years that they call you a pioneer." When Cribier performed the first inhuman TAVI procedure in 2002, he had been developing the concept in partnership with innovators like our own Dr. John Webb for more than 20 years. Now, almost exactly 19 years after that first patient, TAVI is the dominant form of aortic valve replacement in the world. And by 2025, it's estimated that more than 200,000 TAVI implants will be done each year. So you could say it takes 20 years to go from crackpot to jackpot, or to go from where we are today to the moon. And during those years, you are constantly assessing your findings, accommodating the needs of your team and your funding streams, and ensuring patient safety. The point is, it takes incredible courage, tenacity, and sheer stamina to put forward the truly radical ideas that may one day change the face of medicine. We are fortunate to have so many of those courageous and creative researchers bring their ideas and determination to St. Paul's. And today we're going to hear from three of them. They're here to share their moonshot ideas that will shape the way we care for patients in the future. I can't wait to get started, so I'm going to turn the event over to our moderator, Randine Neal, Senior Communications Specialist with Providence Healthcare. Randine?
Thank you so much, Brooke. Thank you. And I too want to express how deeply grateful I am to be here on the unceded ancestral homelands of the Musqueam, Squamish, and Tsleil-Waututh. I try to cherish every day the plants, trees, flowers, and birds that this land so abundantly shares. And I am so delighted today to moderate this afternoon's webinar. First, a few housekeeping notes. Our presentation today is being recorded, so we can share it with those who are unable to attend. Only the presenters and panelists will be visible on screen. You, the viewers, are not on camera, and everyone will stay muted. This afternoon's event will wrap up with a Q&A, probably 15, 20, 25 minutes. So here's your chance to ask questions. You can type your question into the box, the question box, and hit enter. It'll be screened and then posted to the chat. You can also upvote your questions by clicking on that little chevron next to the question box. And submit your questions now as you think of them. There's no need to wait until the start of the question and answer period. So let's get started. As Britt mentioned, today's speakers share a bold vision for the future. They are on the leading edge as innovators and champions of change. We're going to start with Dr. Shona Nolan. Dr. Nolan is a clinician scientist at St. Paul's Hospital and the BC Centre on Substance Use. She is also the inaugural recipient of the Stephen Diamond Professorship in Addiction Care Innovation. Dr. Nolan and her team are investigating evidence-based approaches to improve care and outcomes for people with substance use disorder. Just last month, we passed the grim 5-year anniversary the declaration of BC's opioid crisis. And it's a stark reminder that Dr. Nolan's work and her colleagues' work are more important and more impactful than ever before. So let me introduce you to Dr. Shona Nolan.
Thank you so much, Randine. And thank you so much for the opportunity to speak at the event today. I feel so honored to be speaking alongside my esteemed colleagues. I walk today about addiction medicine, and I really think that in order for us to characterize where we're going on the road of addiction medicine, it's so important for us to acknowledge the path that we've already taken. So today I'm hoping to take you on a bit of a journey around addiction medicine and what accomplishments we've had at Providence Healthcare, and touching on what the future holds for us. I have no conflicts of interest to declare, and I do acknowledge that some of the images taken from my presentation are from some online news sources. I thought I would open it up by just asking people to reflect on some of the images that come to mind when they think about addiction. For some people, they may see images such as these. As an addiction doctor, I can tell you that addiction looks like this, and this, and this. Addiction is a chronic relapsing disease that knows no boundaries. It crosses all ages, all demographic profiles, all socioeconomic classes, and it incurs an incredible cost here in Canada. Beyond the unprecedented number of lives lost to the opioid crisis, the figure estimated in 2017 for the impact of addiction in Canada is almost $50 billion, with healthcare expenditures being second to lost productivity. That equates to almost $1,300 per person in our country. Despite high prevalence and the high cost of substance use disorders, it's widely recognized that most healthcare providers do not adequately know how to screen for, diagnose, or treat addiction. This is a quote from Columbia University in 2012 that still rings true today, that says, "Addiction care is usually provided by unskilled laypersons. Most medical professionals who should be providing addiction treatment are not sufficiently trained to diagnose or treat it." This would be the equivalent of you presenting to the emergency department to seek help for a heart attack and being seen by a doctor who has had no formal training in cardiology. Here at Providence and St. Paul's Hospital, we have been working tirelessly to weather the needle and ensure that every patient that presents to hospital can access evidence-based addiction care. Our journey starts back in 2013 by a generous philanthropic donation from Goldcorp. Their generous $5 million donation laid the foundation for what now is North America's largest interdisciplinary addiction medicine clinical fellowship training program. In 2014, they graduated their first cohort of 4 doctors, and since that time have trained over 50 doctors in specialty addiction medicine. Beyond that, they also have created a nurse practitioner, nursing, social work, and pharmacy stream, which means since 2013, at St. Paul's and Providence, and through the leadership of the BC Centre on Substance Use, almost 100 interdisciplinary care providers have received specialty addiction medicine training. Parallel to a renewed focus in addiction medicine education has also been a profound expansion of St. Paul's Hospital's addiction clinical program. Our inpatient addiction service was staffed in 2013 by 2 physicians. We now have a complement of 25 physicians from a variety of clinical backgrounds, including family medicine, internal medicine, emergency medicine, public health, and psychiatry. With the expansion of our clinical program, we have been able to increase access to specialty addiction medicine consultation for patients. In 2013, we were asked to consult on over 1,300 patients in 1 calendar year. Our workload has tripled over the last 6 or 7 years alone, whereby we're seeing now over 4,500 per year, which equates to about 12 new patients every single day. We also have been able to provide hands-on clinical experience and expertise to medical trainees in the area of addiction. We are training on average over 300 medical students and residents, all of whom will take those skills with them to their respective hospital or community practices. However, despite this expansion in education and clinical services, unfortunately, 2016 saw the declaration of our public health emergency, largely as a result of an unprecedented number of illicit drug deaths, which now surpass the number of drug deaths from suicide, motor vehicle accidents, homicides, and prescription drugs combined. The emergence of fentanyl in the illicit drug supply has and continues to fuel the opioid crisis. And as a response, St. Paul's Hospital opened our on-demand, low-threshold addiction treatment center called the Rapid Access Addiction Clinic. The clinic itself is truly interdisciplinary in nature, with a healthcare provider team of physicians, nurses, social workers, peer support specialists, and admin staff. We opened our doors in 2016, and since that time have seen over 8,300 patients. The vast majority of patients presenting to the clinic, 55%, are self-referrals. 70% of patients coming to clinic are accessing help opioid use disorder. We've started almost 4,300 people on some form of opioid agonist treatment like methadone or Suboxone. We see on average 40 new patients per week, and we've transferred almost 3,300 patients to a community care provider for ongoing primary care and addiction treatment. Following creation of the Rapid Access Addiction Clinic, we also saw in 2017 the creation of the BC Centre on Substance Use. For those who aren't familiar, it is an organization that has a provincial mandate to focus on education, clinical care, and research and evaluation in the area of substance use and addiction. With regards to education, I mentioned that they do lead the Clinical Addiction Medicine Fellowship Program, but also have created an online addiction diploma program, which has seen several thousand healthcare providers complete. They also took over the methadone education course from the College of Physicians a number of years ago, and since that time, we've seen almost a 350% increase in the number of prescribers for methadone, Suboxone, and other forms of opioid agonist treatment. Beyond education, the organization has been very active in the implementation and creation of a number of clinical care guidance documents, as well as clinical practice support tools to providers to provide evidence-based addiction care. They've been very engaged in knowledge translation efforts, having trained thousands of clinicians in 41 locations across the province. The organization is also very active in terms of its research and evaluation. It is a PHCRI and UBC affiliated research center. It acts as the national node for the Canadian Research Initiative in Substance Misuse, as well as a node for the US's National Institute on Drug Abuse's Clinical Trials Network, which means that it's active in terms of ongoing clinical trials and observational research. The organization is very outcomes driven. It is funded through a number of peer-reviewed grants from both CIHR and the US's National Institutes of Health, has hundreds of peer-reviewed research articles, has engaged in systematic reviews and meta-analysis to support the foundation for their guidelines, mobilizes health system data for utilization and outcome evaluation, is involved in implementation research to improve the system of care. In its first year of operation, the BCCSU saw over 50 publications, with a quarter having students as first author. Beyond the academic arena, the organization is heavily engaged in knowledge translation in a number of media outlets. In 2019, we saw the synergy of Providence Healthcare's addiction medicine clinical program, as well as the BC Centre on Substance Use, through the creation of its interdepartmental division of addiction. And that relationship saw a tremendous narrowing in terms of the knowledge to clinical practice gap. The two organizations have embarked on a number of successful initiatives, one of which most recently has been the creation of St. Paul's Hospital's Opioid Stewardship Program, with the goal being to improve opioid prescribing practices at St. Paul's Hospital in order to reduce or prevent adverse opioid-related events like overdose, while at the same time improve or maintain adequate pain control. In its first year of operation, we identified almost 6,000 patients that were admitted to St. Paul's Hospital and were identified to have at least one high-risk opioid order. Our program was able to screen over 3,000 patient encounters. We included just over 1,000 and offered almost 1,600 recommendations to improve opioid prescribing amongst 576 patient encounters. We have recently achieved sustainable funding for the program at St. Paul's Hospital. And when Calvin Siddell's mother heard about the program, she reached out to me to endorse her support for it and told me a little bit about Calvin. She said, "My son Calvin was admitted to hospital in November 2018 surgery. He was prescribed opioids to help control his pain. Prior to having surgery, Calvin had never used opioid medications. He was a business owner who loved the outdoors and maintained an active, healthy lifestyle. When Calvin's prescription ran out after surgery, he bought from the streets, and one of those pills was laced with fentanyl. Calvin died of an overdose just 3 months later on January 6, 2019, at the age of 32 years. He left behind his beloved fiancée, sister, niece, and parents. His tragic death devastated our family and community. I believe had an opioid stewardship program like the one being piloted at St. Paul's Hospital existed when Calvin was hospitalized, he and many others like him would still be alive today, and our family would not have had to go through this horrible nightmare." Another quote from a patient who directly was involved in our program states, "I was extremely hesitant to get help from the St. Paul's Opioid Stewardship Program. I had traumatic experiences before with the pain team making me feel horrible, cutting off my meds too quickly, and so I'd go into withdrawals and just making me feel like something was wrong with me. I took a chance on the stewardship program and was very glad I did. I got the help I needed, a very reasonable slow taper off my meds, no withdrawals, and full support. Not once was I meant to feel the stigma surrounding the chronic pain and opioid use. I'm now free of all pain meds, and I'm very grateful for the support from Tamara and her team. I would 100% recommend this to anyone struggling." And lastly, a patient who states, "I went from a place of taking oral hydromorphone and experiencing micro-withdrawal multiple times a day, and spending more than 60% of my day staring at the clock to see when my next dose was, to now having a medication that I take once a day and don't have any issues with pain or withdrawal. It was like day and night. It was so important to me and my family. I wasn't even able to engage with my children because of the withdrawal, and my children didn't understand. We are so grateful for this program. It is truly invaluable for me and so many other people who are struggling. It was only with the expertise of the opioid stewardship pharmacist and the addiction doctors and taking the time to review all of the options and make a decision together that I was able to make this big change. If someone asked me if this program should continue, I would say that it is a no-brainer and that this one small program can make a big difference." Hopefully, I've been able to highlight the tremendous amount of expansion and success we've had with the addiction program over the last short number of years. In terms of what's next, unfortunately, we still face a grim reality. Maybe many of you had seen this headline in the news that states more than 7,000 lives lost to toxic drugs in 5 years, and this BC health crisis is only getting worse. Despite the tremendous success we've seen at Providence Healthcare, we still have an amazing amount of work to do to ensure a functioning system of addiction treatment within the province. And I think this quote from Evan Wood sums it up nicely. We spend huge money on the consequences of addiction, but we haven't traditionally made the investments in a thoughtful approach to the prevention and effective treatment of addiction. And with that, I'll leave it there, and thank you very much.
Dr. Nolan, thank you so much. And I know that I echo the feelings of everyone listening to you today, how grateful we are for the work that you're doing and the lives that you're saving and the lives that you're changing. So thank you so much for that. And a reminder, if you have questions for Dr. Nolan, please put them in the chat. You don't have to wait until the very end. And if you see a question you do like, you can go ahead and upvote it. For our next presentation, sadly, we're shifting to our other health crisis. We are now well over a year into the COVID-19 pandemic. Dr. Don Sin has been on the front lines from the very beginning. Dr. Sin is ranked number 2 globally for his work and innovation in COPD. He's number 1 in our hearts. He is the Delazari Chair at the Center for Heart-Lung Innovation, and over the past year, he and his team have further distinguished St. Paul's Hospital with a number of landmark studies about the coronavirus itself, testing and vaccines, and the ways we can mitigate, treat, and maybe even prevent COVID-19. So I'm proud to present Dr. Don Sin.
Well, thank you, Rendine. I hope people can hear me. Thank you for the nice introduction. Unfortunately, we're still in the middle of a COVID-19 pandemic. We're experiencing our third surge. And of course, it is a pandemic. It not only affects Canadians, but people right around the world. And to date, over 3.2 million people have died from COVID-19. The largest country suffering the burden of COVID-19 has been the United States. But as we have seen recently in the news, India is catching up very, very quickly. And there are now over 230,000 Indians who have passed away from COVID-19. These slides were made only a week ago, and the numbers have jumped by 15 to 20% in India. So this is a pandemic that unfortunately is lingering and causing a tremendous amount of morbidity and mortality. There is, however, some good news on the horizon. This is the number of cases per million individuals in 3 countries. Canada is represented in the blue line, and we've done fairly well from a global perspective in terms of the number of cases of COVID-19. Two nations that haven't done as well as Canada are Israel and United States. But what's notable is that since February of this year, the rates of COVID-19 in those 2 countries have plummeted to the point where in Israel, I do not think they have a single death from COVID-19 now. So what has changed in those countries that have made these graphs possible? So before we get to that, let me explain to you a little bit about COVID-19. It's caused by a virus, and the virus is called SARS-CoV-2. And it is a respiratory virus. You inhale it. You do not get it from surfaces. You do not get it from touching other people. You get it from inhaling this virus through a close contact. And once the virus gets into the nose, it binds to a receptor. It has to bind to a receptor, otherwise it cannot penetrate into the host. And the receptor's name is ACE2, angiotensin converting enzyme 2. And it's widely expressed in the nasal cavity, but it's also expressed in the airways and in the lungs. ACE2 is a physiological protein. We actually need it. Some of you may be with high blood pressure, maybe on ACE2 or ACE inhibitors, and these drugs block various pathways of ACE2. So ACE2 is a physiologic protein that's required in the body, and yet the virus uses this receptor to get into the host. One reason that children don't develop COVID to the same extent as adults is that ACE2 expression, the amount of ACE2 in their nasal cavity, in their nasal mucosa, is quite small relative to adults. And it's shown in this slide. On the y-axis is the expression for ACE2, and in the x-axis is the age category. And you can see that below less than 10 years of age, there is very little expression of ACE2. So with this thought in mind, we performed this study at St. Paul's Hospital where we perform bronchoscopy, and that's a little telescope that we insert into the mouth and then subsequently into the lower airways using a telescope like this. We did this in 42 individuals. Half of them had a disease called COPD or emphysema. The other half did not. They were healthy adults, and they're well matched, and their demographic features are shown here. And what we observed on the first panel was that the ACE2 expression was much higher in the COPD subjects than in the healthy controls. And the middle panel shows that there's an inverse relationship between lung function as measured by FEV1 and ACE2 expression measured on the y-axis. And it's as the lung function decreases from 120 to 40, ACE2 expression in the lower airways increases. Smoking, current smoking at least, also increases ACE2 level, and that's shown in the third panel. And we showed this not only as a gene expression, but also as protein. And this is, we do staining of the lower airways using lung blocks, and showed in the final panel to the right that COPD patients had increased protein levels of ACE2 in the lungs. So with that thought in mind, we then asked the question, can we reduce ACE2 in the lungs of COPD patients using inhalers? And the inhalers that we used or evaluated are shown at the bottom right, purple puffer and a red puffer that were evaluated. And to make the long story short, over a 3-month period, we showed that using these two puffers that contain inhaled corticosteroids reduce ACE2 expression levels in the lungs of COPD patients, and thus reduce the risk of COVID-19. There's another protein that we also reduced by giving inhaled steroids that are, and this protein is very, very fundamental to how the SARS-CoV virus enters into the airways. And so these findings are translated into clinical improvements of patients. This is a Kaplan-Meier curve, what we call a Kaplan-Meier curve from a study called STOIC, where they evaluated individuals who caught COVID-19, but were not terribly sick, but nevertheless had COVID-19 by a nasal swab. And they followed them over a 28-day period. One half of those individuals, as shown in blue, received the inhaler, shown here in the middle, and the red are the control group that did not. And what this is plotting is the probability of full recovery. And you can see that those who took the inhaler by 2 weeks had fully recovered. 100% of them had fully recovered, whereas those who did not receive the inhaler, about 25% did not recover even to 1 month. So tremendous benefit of inhaled corticosteroid containing inhalers. So that's therapeutics. How about prevention? Well, to understand prevention, we have to know how COVID-19 spreads, or how COVID-19 came to Canada. And it came through air travel. And in Canada, we imported the first cases of COVID-19 from Asia, as well as Iran, and subsequently from other places, and we also exported COVID-19 as well. So air travel is one of the predominant routes of international spread of COVID-19. To identify COVID-19 patients before they become terribly ill is through testing. And we've heard lots about testing, including nasal swab testing. In hospital, we use testing known as PCR. This is a molecular test that is highly, highly sensitive and accurate for diagnosing COVID-19 in hospital. However, there are some limitations to that, which we'll get into in a minute. So there has been an invention called rapid antigen test that can address the limitations of PCR testing and provide quick and fast and accurate results to the patients. And this graph just shows you where this rapid antigen test can be deployed. And it can be deployed in this middle area called infectious. When the individual is infectious, we can use rapid antigen tests to identify those infectious individuals even before they become symptomatic, and institute preventive therapy. So here's a comparison of what rapid antigen tests are compared to clinical PCR testing. And so the main selling point for rapid antigen tests is that the test results can be obtained within 15 minutes. So, and when we compare rapid antigen tests head to head with a PCR test, they perform very well with a specificity of 100%. So if you get a positive screening test, that means you have the virus, no doubt about it. Sensitivity is between 70 to 80%, but in the middle column, when the individual is infectious, the sensitivity, the ability of the rapid antigen test to pick up the virus increases to 95 to 98%. So it's very good at identifying infectious individuals. And here's an example. It's almost like a urine pregnancy test. 1 bar indicates you're negative, 2 bars indicates that you're positive for the virus. And so we then ask the question, can we deploy this rapid antigen test at places, high-risk places like the airport? And we, in partnership with WestJet and YVR, deployed a rapid antigen test at the departing range on domestic flights. And so we told the passengers if they tested negatively, they were free to board, but they would still have to socially distance, mask, and use hand hygiene during their travel. If they tested positively on the rapid antigen test, they would be denied boarding and they would go into quarantine until the another PCR test showed that they were negative. So with that in mind, we performed this study between November 23rd and February 28th. That was just the schedule of our study. And we approached 627 passengers, 35 refused. And the number one reason for refusal was the fear of missing a flight in case they tested positively. So 29% of the 35 refused on those grounds. That was followed by concerns about false positives and fear of nasopharyngeal swabbing also played a small role. But vast majority participated in this study. And so when we looked at positivity rate, we found 0 positive out of the 592. Both on the rapid antigen test as well as PCR. So all of the negative tests underwent PCR as well, and they were negative. Just as a comparison, we employed basically the same design at a long-term care facility in Vancouver and surrounding region. And of the first 702 subjects tested there, 2 were positive on the rapid antigen test as well as PCR, showing that this can identify positives. At YVR, during our study period, we did not identify any positives. So if we look at or try to project into the future, how can we get out of this pandemic? What is the key to normacy? And you've probably heard of herd immunity, and there's a lot of debate as to whether we can or cannot reach herd immunity. But if in the population, 60% plus develop antibodies or robust antibodies or T-cell immune responses against the virus, then herd immunity would be achieved. And realistically, the only way to do so would be to use vaccination. And these are the projections in the United States in February, and they've reached those goals. And why is vaccination critical to containing or even eliminating COVID-19? Well, the data are compelling. This is Israel, who has been at the forefront of vaccination. they've fully vaccinated over 60% of the adult population. And this slide shows the incidence of COVID-19 in those vaccinated, as shown in blue, and those not vaccinated, shown in orange. And days from vaccination are shown in the x-axis. And you can see that by 2 weeks, the vaccinated individuals have much lower rates of COVID-19 compared to the unvaccinated. And the curves keep on diverging. And same with hospitalization, and same with death. So there's no doubt that vaccination is the key to returning us back to our pre-pandemic state. Unfortunately, Canada has lagged behind significantly other parts of the world. As noted, Israel, United States, and UK have been the leading nations, at least big nations, in vaccinating its population. We need to catch up, and we must accelerate our vaccination efforts. And this final slide shows the effect of vaccination. So all the mitigation interventions are much better in Canada than in the United States, but yet the rates of COVID have dropped below, in the United States, have dropped below Canada, and that's because of the pace of vaccination. So I think the future is bright. It seems kind of dark now, but I think that over the next few weeks to months, as we accelerate our pace of vaccination, we will achieve herd immunity or close to it, and that will drive down the rates of COVID-19 in our community. With that, I want to thank the organizers for inviting me to this symposium. Thank you.
Dr. Sin, thank you very much. And you received an influx of questions there, including whether we should all run out and buy steroid inhalers. But we'll get to the questions after our final speaker today. Thank you so much, Dr. Sin. And a quick reminder, if you do have any questions, please put them in the chat. Our last presenter today is Dr. John Webb, and he needs no introduction. By title, he's an interventional cardiologist and director of the Center for Heart Valve Innovation at St. Paul's Hospital, but that does not convey the impact he's had on revolutionizing patient care and outcomes at St. Paul's and across the globe. He was on the team that pioneered the first TAVI procedure with Professor Cribier, and he spent the last 20 years perfecting those techniques, improving the valves themselves, and training other doctors around the world to do the procedure. And a quick note for anyone who may be a little bit squeamish, we do see some of the TAVI procedure, which is very cool, in Dr. Webb's slides. So without further ado, Dr. Webb.
Gee, thanks very much. I'll just change my view here. So, I guess the issue is, what will we do when our heart valves wear out? And we've had solutions to this for a long time, but they're not ideal. This is a picture on the left of a human aortic valve. Now we have 4 valves in the heart, and this is the one that is under the most pressure. Of course, it opens once every heartbeat, the aortic valve. That's 60 times a minute, billions of times over a lifespan. And what it means is that in many people, as they get older, the valve gets thickened and scarred and calcified, like the autopsy specimen on the right, which shows disease of the aortic valve where it's thickened and just doesn't open properly. We call that aortic stenosis. Stenosis meaning just that it doesn't open properly. Now, we have surgical options these days, and this shows the first implants of the aortic and mitral valve back in the 1960s. It's a ball and cage valve named for obvious reasons. And some years later, saw the development of tissue heart valves, which are now most commonly used. They consist of either cow or pig heart valve tissue, and they work really very well. But the problem, of course, is that you have to do open heart surgery to do this, and this involves big incisions and the heart-lung machine, and very successful procedure and still very, very useful, but not something you want to have done if there's other ways to get around this, particularly because many people, when their valves fail, they tend to be older and just don't tolerate surgery very well. So back in the 1990s, we and a lot of other people started working on transcatheter heart valves, and coronary artery stents were being developed, and many of us thought if we had a really big stent, rather than fix a little artery in the heart, we could actually put a valve inside it and implant it inside the valve that isn't opening properly and just replace the function of the valve. And so we started working this at St. Paul's. There are groups in France and other places as well. The first implants were accomplished in France, but it was very problematic and really not a very successful reproducible procedure. But in around 2005, we reported the first transfemoral valve implants, and this is a picture of an early transfemoral procedure. Femoral, of course, is the big artery that goes down to the leg. So this is an incision over the top of the leg, and we put a big tube in with the valve going through this. Things have improved dramatically, so now we can just make tiny little incisions over the artery and just a needle puncture to do this. And it became really an extremely successful procedure.
What does TAVI mean?
Totally awesome valve implant.
And how old are you now?
96, 97 next month.
And when was your TAVI done?
This morning, 7 p.m., although it was a little late getting started.
And you're enjoying your coffee?
I'm enjoying my coffee.
So it doesn't, of course, mean totally awesome valve implant. It means transcatheter aortic valve implant, but that's okay. So, we were very successful around 2005 with this, and it caught on very rapidly. And in 2007, we built the world's first purpose-built transcatheter aortic valve implantation hybrid surgical operating room. And this gave us tremendous ability to reach the world. We were able to transmit via fiber optic or satellite from multiple cameras and multiple monitors and have audio and really teach people at a distance. And we've just finished refurbishing that specialized hybrid operating room. Now, with the ability to transmit live cases, we did this routinely to huge cardiac meetings across the world. And here's one of the transmissions. You can see there we are in the center with our moderator. We've got two-way communications. We can talk back and forth with literally thousands of physicians in the audience seeing these procedures for the very first time. We went on to teach groups from around the world. Here's the first group in China, Emory University in Atlanta. We've got groups from Europe and other places in Asia. Here we are, the first cases in Japan, all proctored or trained by Vancouver cardiologists and surgeons who went to help with these procedures. We've published tremendously. This is the way we get the information out as well. There's textbooks, and you can see the structural heart disease interventions is now published in other languages as well. I have a Japanese copy in my office, and many publications, over 700 journal publications, which is how we impact the world with this information.
So there
here's a short video of
you can see just the bottom
one of these
the screen.
procedures.
Actually, I felt almost nothing. It was really very easy.
It's done
We're not
through
going
a
to have
needle
to do any
hole.
alignment. We're just going to go straight up to the arch. And I think
Patients
it's gonna be
actually
pretty
awake
easy to
during
process
this. It
thing,
doesn't
even though
really
it's very
hurt.
tight. That was pretty easy.
There's the valve
I
going
think it's pretty well
into
perfectly positioned
the
and
patient's heart.
Coaxial, so we don't have to pull a flex cath back. Let's do an aortogram and just have a look at that, Gideon.
Inject some dye inside
I don't think we need to do
aortic
anything very
valve.
much with this. Let's just accept the perfect position. Now, pacemaker on.
So we're going to pace the heart very rapidly to stop it moving so
Start
much.
going up.
Starting going up.
And then we're going to
Keep on
inflate a
going
balloon
up.
and expand
Just go all the
that
way, David.
All the way.
metal cage with the valve inside it.
1,000, 2, 1,000, 3, 1,000, and down.
During this period, there's no flow through the heart, of
Phaser
course.
off.
Very quick.
We'll unflex. We'll pull this system
The balloon
back.
comes out, and now the
And
valve
that's
is
it.
in. That was it.
How are you
That's the
feeling?
valve implant.
Yeah. Oh, yeah. Did you feel lightheaded for a minute?
Yeah.
A little bit lightheaded? Yeah. You feel good now, though, huh? Yeah, good. Okay. Well, your valve's in. Looks pretty good.
Not easy, eh?
It's that easy. Yeah. Good. We'll just put the
So
loader
that's
directly.
a transcatheter valve implant. People come in the morning, they have the procedure.
So we'll get you up and around later on, okay?
You get out the next day.
The next day.
The next day.
And no problems with that?
Not a bit.
No, we actually went to Joe Forte's that night for supper.
Yeah, well, the valve.
This was pre-COVID, I guess. And this is now the standard of care for many people. Mick Jagger, of course, had one last year. This is him 6 weeks after his valve implant, back at it at 74. These procedures, we had really no idea how long they would really last when we started doing these things. But here's the first patient we did that survived 10 years later. She had her procedure at 87, left the hospital, did very well, and we tracked her down at age 97, and there she is with one of our trainees and one of our echo nurses who visited her at her home 10 years later. We have many patients out long after these procedures, but we do know that eventually these valves do wear out after 5 years sometimes, but usually 10 years or even longer. They're going to last. Many patients who have valves that haven't worn out after more than 12 years now. But the beauty of this is that it can be repeated.
No.
There you can see
Face
there's
her on.
already a valve inside this patient. This patient, it's 10 years later,
Good.
and we're implanting a
Starting to go up
second one
slowly.
inside the first.
Yeah.
Slowly, slowly,
All the way.
all the way.
Yep. All the way.
1,000, 2, 1,000, 3, 1,000, and down.
Face her off. I think we knew it would look like that.
Yep.
The first valve was grossly underexpanded
Yes.
because of annular calcium and porcelain aorta. So
So,
we
you know,
filled this a little bit.
The bottom line is, here's the patient who had a redo valve.
This operation I had wasn't much more than an angiogram.
So the bottom line is it's really becoming the default very rapidly for most people who have a failed aortic valve. We're moving on from there to other valves. I said there was 4 of them. The next most important maybe is the mitral valve, and we did the first in human implant of this particular mitral valve. Here's a little cartoon just showing it. We're grabbing onto the valve. It's a more complicated procedure. On the left bottom is actually an ultrasound image of the new valve we put in this patient in the mitral position. And that's really a very dramatic advance. So we now have a very large program in terms of transcatheter valves at St. Paul's Hospital. It's the largest program, I think, with the most new first-in-man procedures anywhere in the world. There's a large group review our patients every week. We get together and decide what we can offer people in terms of these new transcatheter valves or routine surgery. But things are changing very rapidly for people. I think this is very well received. So thank you very much. And let me see, there's the hope that we'll be able to continue this on at the new hospital.
Absolutely. Dr. Webb, thank you so much. I always love it when surgeons say when they've just completed a procedure that saved your life, yeah, it looks pretty good. So thank you so much for that. We have so many questions and we're running out of time. So I'm just going to jump to them very, very quickly. The most popular question, I'm going to combine it into 2, and it's for you, Dr. Sin. The first question is, what are your thoughts on mixing vaccines with the 2 doses? Could this enhance immunogenicity? And then the second question is, should we be all running out and getting steroid inhalers just to be cautious, especially those of us with higher ACE2 receptors?
Okay, well, the latter one is easier. I think if you have asthma or COPD or something that requires inhalers, I think you should continue them. And if you haven't been on inhaled corticosteroid, you should probably be on those medications. I don't think individuals who haven't used the inhaler should go out and buy them, because they're difficult to use, and if they're not used properly, you'll have nothing but side effects. So the first question is, I think we need to be careful about mixing and matching right now. I think there are some theoretical reasons why it may work, but there are also theoretical reasons why it may not work. So consider it experimental, and I don't think we should be experimenting too widely on the population. So if you had Pfizer, go and get Pfizer. If you had AstraZeneca, go and get your second shot of AstraZeneca.
Thank you, Dr. Sin. The next question is there an update on the building of the new St. Paul's Hospital? And Brooke, I'll get you to answer that.
Great. Thanks so much, Randine. So yes, we have started construction. on the new St. Paul's. If you happen to be in the neighborhood on Prior Street or Station Street or even Main Street, you'll be able to see that construction has started on the site. We do have some cranes up, and we're excited in order to move this project forward. Just for people's information, it is a $2.2 billion project, 1.4 million square feet, and all of the programs that you've heard about here will be major pillars within that new center and that new hospital, and we're very excited about that. Right now, we at the foundation continue to raise funds in order to support that project. And so if you're interested in learning more about that project, please reach out to the foundation. We're happy to chat with you about it.
Thank you, Brooke. We had several questions for Dr. Nolan too. So Dr. Nolan, I'm going to squish two of them together for you as well. The first one is, what new addiction treatment methods are out there now apart from methadone and Suboxone? And also, what can we, the community at large, all of us do to help support your work? How can we help?
Those are great questions. With regards to the treatment options, I mean, there are a number of different medications depending on the kind of substance use disorder that someone has, specifically around opioids. We do have some promising medications coming down the pipeline, one of which we are researching, myself and another member of the BCCSU, specifically at the Rapid Access Clinic, which is an extended release injection. So it's a once monthly injection of buprenorphine. It is great in that it prevents patients from having to remember to take a medication, to have to go to a pharmacy on a daily basis. So it looks very promising in terms of improving overall quality of life, as well as being a very efficacious type of medication. And beyond that, we're also looking at prescribing existing medications in nuanced kinds of ways to help get people onto treatment. And then the second question, in terms of how you can help support, I mean, I sound like a broken record with this all the time, but if you think about the resources that have been devoted to the COVID-19 pandemic, no offense, Dr. Sin, and compare that to the resources that have been mobilized for the opioid epidemic, they really are non-comparison. And so any resources, any funds, any support that people can provide to help us in terms of our ongoing research, but also expand our access to clinical care services for individuals would be greatly appreciated.
Thank you, Dr. Nolan. Dr. Webb, it's your turn. What would be something that would make you incredibly excited or happy to see in the new St. Paul's Hospital with regard to the future of healthcare services, or heart care services, rather?
Well, you know, I would agree with the other two speakers, first of all, that COVID is extremely important and that addiction treatment is extremely important. So I'd put them maybe above some of the things that we do that are very expensive, but for individuals are very important. I think that we can do a much better job in terms of evaluating patients and moving them through the system than we have done. And we're moving towards that, I think, in terms of having heart teams that review patients and determine what should be done. You know, if a surgeon typically maybe wants to do surgery and an interventional cardiologist maybe wants to do a transcatheter valve, and we really are trying to work more and more as a team to make these sorts of decisions with the patients. And that's the direction I think that we're going to be going.
Thank you, Dr. Webb. The next question is for Dr. Nolan from Maria. Can you please comment on how successful the overdose prevention site has been as a means of initiating engagement with the various addiction supports at Providence Healthcare?
Yeah, in response to the opioid crisis, generally we've taken two kind of big bucket approaches. One is improving access to harm reduction initiatives. Those are things like the overdose prevention site. The second is really improving access to treatment, so medications. At St. Paul's Hospital, we did see the overdose prevention site become operational within the last few years. I've seen the data for the site. Specifically, it's had thousands and thousands of visits per year and not one fatal overdose. But beyond that, because of its location, with it being embedded within the hospital itself, it's staffed by nurses who have specialty training in addiction medicine and is very much in tune with our clinical addiction program. So we commonly have what we call peer support specialists. They're usually individuals with lived experiences, and often will meet with people when they go to the OPS and help to kind of entice them to access addiction treatment services. So I work in the Rapid Access Addiction Clinic. I can say anecdotally, I've had a number of patients come in and seek treatment because they have heard about it or had some friend at the overdose prevention site who has experienced it. And they are, it really is, it starts as a harm reduction initiative, but really is a gateway to accessing evidence-based addiction treatment.
Thank you, Dr. Nolan. Dr. Sin, the next one is for you. As the age rollout continues, this in turn has led to greater demands for vaccines. As a retired St. Paul's Hospital RN, my idea would be to have 24-hour clinics in large venues versus the short-lived pop-up clinics, I think, that lasted a couple of days. Do you have any comments or any comments?
I think that's a great idea. I think the bottleneck, to be fair, has been the federal procurement of vaccines to date. So once we have more vaccines, and in the United States, there are more vaccines than people who need to be vaccinated. When we get there, I think we need to have a better strategy of getting the jabs into people's arms as quickly as possible. And that probably means 24/7 clinics to enable, mass vaccination. The sooner we get vaccinated, the closer we'll be able to get into normalcy.
Thank you, Dr. Sin. And I have one last question for Dr. Webb. Dr. Webb, it's about women and middle-aged women. What are the signs and symptoms of a valve problem, and what diagnostic tests would help make a diagnosis? That's a big question. Sorry.
Yeah, well, so the sort of symptoms people get are symptoms of heart failure. That is, the heart can't pump blood around the body, and it specifically can't pump it out of the lungs. So you find you get shorter breath, and shorter breath first is exertion, and then with less exertion, and eventually at rest. Sometimes people get some tightness in the chest with exertion as well. These would be the main sort of symptoms: is tightness in the chest or trouble breathing. And the test that needs to be done, if you're, well, first of all, your doctor would usually have a listen to your heart with a stethoscope, but then it's usually an ultrasound that's needed to make this sort of diagnosis. An ultrasound is a pretty routine, riskless procedure that may be appropriate for people if their doctors really think they have a valve problem.
Dr. Webb, thank you. Thank you to you and to Drs. Nolan and Dr. Sin for sharing all of your time and insights with us. We are at a time that is the fastest hour I've spent in a long time. So thank you to all of you and to all of the participants who listened in and asked your great questions today. And as we move towards the new St. Paul's Hospital, I hope you feel as inspired as I do from these three physicians and clinicians and researchers, and they're whiplash smart, and the ideas and vision that they're going to bring to the new hospital is going to be absolutely amazing. The one thing that won't change, though, is the heart and soul of St. Paul's. It's a team of more than 6,000 strong, talented, tenacious people, like these three you met today, these four you met today. They're not mavericks, as Brooke promised he wouldn't call them earlier, but they are definitely aiming for the moon. So we thank you all again for what you're doing for all of us. And we thank you for listening today. Have a good afternoon, everyone.